Greetings, everyone. I am so happy and proud to present to you this whole series on diabetes. We all know the statistics that more people than we could even imagine have been afflicted by diabetes, type 1, type 2 diabetes. And so this entire series talks about diabetes. What can we do? Can it be prevented? What can you do to control it? Do you have to stay at a type 2 level the entire time? And I could not ask for a better host, a better partner than the Pitts Foundation, the Jack Pitts Foundation, Health Foundation, as well as the Links Incorporated for Lansing, East Lansing Links Incorporated. And also Michigan State University has been a tremendous partner in this, in helping us to pull together this entire series. So it is indeed my pleasure to present to you our host for the day, someone who I can proudly call my friend, someone I've known for decades, and that's Jack Pitts. Jack Pitts has his own story to share with you. I'm not going to share his story, but he is an overcomer. He is a warrior. He has been a phenomenal athlete all of his life, someone that we've watched and just admired in terms of that athletic prowess. But I think he would share with you the biggest fight of his life has been his health, and he has overcome that as well. And as a result of what he has done, he has created, and wanting to give back, he created what's now known as the Jack Pitts Health Foundation, and it has given so much back to communities across this great state. So there really is no better host for today, for this entire series, than Jack Pitts, who is CEO of the Jack Pitts Health Foundation, someone who has lived this life and has pulled together a tremendous amount of people to help give back and help fight this disease called diabetes. So with that, AARP is proud to present to you our host for this series, Jack Pitts. Hi, Jack. How are you?
Hi, Paula. Thank you. I am very happy to be here.
Well, I'm very happy to see you. I know some of your stories and I know what you've gone through, and you look like a picture of health. So your being here is an inspiration to so many people, and we want to get right at it. So I'm going to get off the screen and let you introduce our wonderful panelists. But I want to say to you again personally, thank you so much for joining AARP Michigan. We have 1.3 million members here in the state of Michigan, and we have, we work with older adults. That's our primary target. And people of all ages, not just older adults, but younger adults, everyone, young people, everyone is afflicted by this disease. So I hope if you're watching, ladies and gentlemen, you'll call someone, have someone look at the link, actually join the link, or else watch it later on if you have to. Ask questions. It's going to be very interactive. Thank you, Jack. I appreciate you.
Thank you, Paula. As Paula mentioned, I am the founder and president of the Jack Pitts Health Foundation. And through the years, we started in about 2017, making contributions to various organizations. We started with breast cancer, we went to prostate cancer, and for the last several years, we've done diabetes. Also, additionally, we have sort of partnered with AARP. We did our own health and wellness luncheon 2 years ago, and so we're trying to combine donations to organizations with outreach. I'm also a diabetic, and in 2009, I went to see my doctor about acid reflux. My doctor, who was a friend of mine, said, let me take your blood, and if there's a problem, I'll call you back. Well, he called me that Monday. That was a Thursday. He called me that Monday, said, you need to come in and see me. I said, man, I got to work. So I don't go in for a whole week. Bottom line was my blood sugar was 635. And he told me, he said, just by the grace of God, you didn't have a stroke or a heart attack. So this information hits home to me. We hope that you enjoy it. As Paula mentioned, this series will focus on demystifying diabetes and answering all your questions. Today, our presenters will share with us what prediabetes is, how you can know if you're at risk, and how you may be able to turn it around with nutrition and lifestyle changes. If at any point you have something to say or want to ask a question, I invite you to be part of the conversation and put it in the chat. We'll all have lots of time for questions in the second half of the program. We'll do our best to answer as many questions as we can. Now let's get to know our presenters. Dr. Akambi is a board certified in endocrinology, diabetes, and metabolism, and has been in practice for over 20 years. She completed an internal medicine residency and endocrinology fellowship in Nigeria. Due to her passion for the field of endocrinology, after completing an internal medicine residency in the US, she proceeded to the University of Michigan for a second fellowship, training in endocrinology and metabolism. She has several peer-reviewed publications and is passionate about medical education and patient education. Natalie is a registered dietitian nutritionist at her private practice, Evermore Nutrition and Wellness, where she specializes in disease management and prevention, including diabetes management and weight management. Passionate about the transformative power of nutrition, Natalie is dedicated to helping individuals achieve their health goals and live their best lives. In addition to her expertise in counseling and education, Natalie is also a helpful recipe developer. She creates dishes to not only nourish the body, but hopes to inspire people to step into the kitchen and embrace deliciously wholesome lifestyles. Welcome to both of you, and thank you for being here today to share your knowledge and expertise. We're going to hear from Dr. Kanbi presentation first, and Natalie will follow afterwards with everything you need to know about diabetes and nutrition. Let's get started.
Good morning, and thank you so much for having me here. I'm very excited to talk about something that's close to my heart because it's also personal for me. I have pretty significant family history of diabetes on both sides of my family. I have been diagnosed with prediabetes myself, so glad to be here to share information that can be helpful for everyone here today. So we're going to start with the why does it matter? Why are we even talking about prediabetes? And to talk about, before we get to that, I'd like to define what diabetes itself is. So this is a condition where your body either doesn't make insulin or makes it but doesn't use it well. So type 1 diabetes is when your body attacks the pancreas, which is an organ on the left side about the body to about the center that makes insulin and other things that break down your food. Insulin's job is to, when you eat, drive the glucose in, make sure the fat and the protein in your food is stored for the future, and essentially keep your glucose at a particular stable level. When your body attacks itself, autoimmune in nature, you make antibodies, that's usually type 1. In that case, people tend to present quicker at a younger age with diabetes. For type 2, it tends to be more a case of you're still making some. In fact, at one point, you might make even more insulin than usual because your body is still trying to address the fact that when you eat, your sugar rises quite quickly. But after a while, with long enough time, there can be progression to where the pancreas stops making insulin, and you do end up needing to get insulin therapy, even if you've been on medications prior to that. So there are other forms of diabetes. It can be due to infection, using medications, a type that occurs in pregnancy. And then now to talk about prediabetes itself. So this is the state that precedes full-blown diabetes. This is especially important for the type 2 because in that stage, this is that phase. Sometimes it can be years, 20 years, 30 years. There is no one size fits all where the body is still trying to compensate for the ineffective use of insulin. And so if measures are taken, we can prevent people developing diabetes. So onto the magnitude of the problem, why it's important to identify prediabetes. In the US, about 30.3 million people have diabetes itself. That's about 1 out of every 10 people. And about 1 out of 4 people, about 25% of those people, do not even know they have diabetes. And so this is diabetes to start with. For prediabetes, there is almost 3 times the number of people in the US that have prediabetes, about 84.1 million people. So that's 1 out of 3 adults. So these numbers are mainly focused on adults for the prediabetes figures. 9 out of those 10 people, so 90% of people who have prediabetes are not even aware, because a lot of times there are no symptoms. For diabetes, people might be like, I'm thirsty, I'm peeing, I'm eating a lot, I'm losing weight, because even though you have a ton of glucose in the blood, insulin is not taking it to the cells. So I describe this to my patients as starving in the midst of plenty. There's a lot of glucose, but it's not going to where it's needed. So your body senses that, and then it's like, I'm going to break down protein. I'm going to break down fat that you have stores. And so that's how people lose weight. But in pre-diabetes, things are not that far advanced. So people might not be aware. That's why 90% of people wouldn't know, because no symptoms. It's not that severe. You're not peeing a lot because this glucose might not be spilling, overwhelming the kidneys. And people who have pre-diabetes, by losing weight, can actually reduce their risk by 50% with losing weight and eating healthy and exercising, which is why we're talking about let's turn it around, because there's something we can do to prevent you progressing or people progressing to diabetes. In terms of the magnitude of the cost for the healthcare system, about $245 billion is spent every year on medical costs, but also on wages lost because people have to take time off. Maybe they're having bypass surgery because they have blocked heart vessels, or they've had a stroke and they're in a hospital, or they're getting dialysis 3 times a week, or they're waiting to get transplant, or they get a transplant. There are many complications that diabetes can cause that can affect not just the health, but also productivity. So that we'll talk about morbidity with like, okay, the risk of dying, which is about, in patients who have diabetes, 50% higher compared to people who don't have diabetes. And then the morbidity will be the complications that can happen. And there, some of them are listed here below: blindness, kidney failure, heart disease, whether that's heart failure, the heart doesn't pump as well, so people have fluid retention, or even blocked vessels, stroke, loss of toes, feet, or legs because there are ulcers that don't heal well. And people who have diabetes actually have medical costs that are about 2 times what people with without diabetes have. So that also affects, of course, quality of life for our patients. So this just points to all the reasons why, if we can prevent people getting diabetes, it's certainly something worth spending time and attention on. So to talk a little bit about how do we make the diagnosis. So I will start by talking about diabetes itself. Usually we do 2 tests. We need 2 numbers that are abnormal. There are 3 possible ways of diagnosing diabetes. You could go to the lab and you have a blood draw, and so you're fasting, and fasting is defined as you haven't had anything to eat for 8 hours. It's usually something overnight, like post dinner. So people eat dinner, go to bed, and you wake up. Most of us will sleep about 6 to 8 hours. So hopefully you haven't eaten for about 8 hours. You go to the lab. If your blood sugars are above 126, that could be suggestive of diabetes. But we need more than 1 number, because maybe you had a slice of cake or ice cream the night before. That can affect either your fasting or if we test you randomly after a meal, that could be a reason. It might not mean that you have diabetes. It might just mean that you had a lot of calories. That's the rationale for having 2 abnormal values. There's a test that we do where we have people drink 75 grams of glucose. That's called the oral glucose tolerance test, this right here. And patients come in fasting. We do a blood test before the test to see whether their numbers are above 126, and then they drink this mixture, and 2 hours later we then test their blood sugar. And if the glucose, and I'm using sugar and glucose interchangeably, I mean to say, if the sugars or the blood glucose is above 200, then that will also reflect possibility of diabetes. If you do this test twice, or the fasting twice, or you do one of them, and you can do them the same day, days apart, and they are abnormal, or you have an A1C that's above 6.5 or equals to 6.5, Any of this three, two of this three together will be diagnostic of diabetes. Now, what is A1C? A1C measures how much glucose is attached to your red blood cell for the past 3 months. Our red blood cells last an average of 90 to 120 days. And so this is less affected by fasting. Did you eat? Was it because you ate something? This tells us for the past 3 months, your sugars have been high. And we like to do this. In fact, this is a great test in clinic because when people come for follow up for us, we don't have to worry about, are you fasting? How many hours ago did you eat? We get this test and we can use that. This is something that's done, of course, every 3 months, and we can compare how are you doing the last visit. Are things better? So having defined diabetes, we can now go to pre-diabetes, which is the lead up to, it's the condition that precedes diabetes. So when you do a fasting and the numbers are between 100 and 125, that shows us that when you're fasting, your body does make insulin round the clock, but that insulin is not enough. It's not able to keep your sugars less than 100, which is the normal, even when you're not eating food. When you've eaten, and 2 hours after, we expect your blood sugars to be less than 140. So when we do that oral glucose tolerance test, which is the shortened form is OGTT, and figure the numbers are between 140 and 199, that is termed a form of prediabetes known as impaired glucose tolerance. That means every time you eat, your pancreas struggles to bring your glucose back to normal, and that's also a precursor of diabetes. And then for the A1C, numbers between 5.7 and 6.4 are diagnostic of pre-diabetes. And in this wise, any one of the three is adequate. You don't need two abnormal tests in this case. They only need two abnormal when we're diagnosing diabetes. For pre-diabetes, any one of these numbers should make you talk to your primary care doctor or any provider to try to do further evaluation for you. And I already did talk to some of the symptoms of high blood sugar. Anyone that has the symptoms, I'm drinking a lot of water, I'm peeing a lot, and I have high blood, I'm hungry, I'm losing weight, and the glucose is above 200, even without having two tests, that those symptoms combined with a high blood glucose are diagnostic of diabetes. So who should be screened? Because yes, now we know what points us to how we make the diagnosis. Who should get tested? Anyone who has a weight, but BMI. So your BMI, which is your body mass index, is the weight in kilograms or pounds divided by your height, and the height is squared. So, and the height is usually, of course, in meters. So for a BMI above 25 or equals to 25, that's overweight. But for Asian Americans, we use a lower BMI cutoff of 23 because they tend to develop all the constellation of diabetes, hypertension, and maybe things like sleep apnea, which is when people had disordered breathing at night when they're asleep, at lower BMI. So BMI above 25, that's a risk factor. Anyone that has first degree relatives, so that's mother, father, brother, sister who has diabetes, you should be getting tested for pre-diabetes or even diabetes itself. If your ethnicity or race is African American, Latino, Native American, Asian American, Pacific Islander, we just have higher rates of diabetes in this population. And so it's a good idea to get screened. Anyone with a history of having had a stroke, a heart attack, a heart failure, because these are all complications that can follow diabetes, that it's a good idea to have any of those tests, easiest one, A1C checked, just to rule out as a contributor. High blood pressure, so numbers above 130 over 80, or your own medications for hypertension, you should be getting screened for pre-diabetes. The reason is there's a common underpinning between these conditions: high blood pressure, weight, diabetes, gout, sleep apnea, and something that happens in women called polycystic ovarian syndrome. Remember I talked about in type 2, people don't use insulin well. We call that insulin resistance. So your body makes it, but your body is not sensitive to it. that is something that tends to have associations with high blood pressure, cholesterol being off, and I'll talk about this in a bit, diabetes. So any one of those should make us, we tends to make us look for the other things. So if your cholesterol is low, the good cholesterol that we call HDL, A1C, or any of the other tests should be checked. Triglyceride is a form of cholesterol that comes from food, usually related to eating saturated fats. Reading labels, I'm sure Natalie's going to talk about that. So, this is a reason to take a look at the labels. If you have a lot of saturated fat in your food, you're probably going to have issues with triglycerides going up. So, this cut off above 250 should be screened or tested for diabetes. I already talked about polycystic ovary syndrome. So, anyone that has that diagnosis, we will order any of these tests. If you're physically inactive, and we describe activities at least 30 minutes, 5 days a week of walking. Some studies have shown that exercise done right after eating probably even works better. Even if you're doing 10 minutes 3 times a day or 15 minutes twice a day, any exercise is better than none, because that just increases inactivity, increases the risk of insulin resistance. Other things, I already alluded to this: obesity, acanthosis nigricans is having dark skin, dark around the neck, the elbow, or the armpit. It is a marker of insulin resistance, and so it will make us go check whether they have high blood pressure or difficulty managing glucose. Anyone who's had pre-diabetes in the past, so defined as an A1C above or equals to 5.7, should be tested yearly. So this answers how often. So now I have a diagnosis. Natalie will talk about, I'll talk a little bit too about what to do to prevent progression, but how often should you be tested once you have the diagnosis? Once a year. People who have diabetes, we're testing them every 3 months. Pre-diabetes, once a year at least is sufficient. People who had diabetes during pregnancy will have testing every 3 years for the rest of their life. The reason is the risk of developing diabetes if you had pregnancy related diabetes. So, gestational diabetes only occurs while the patient is pregnant and goes away once the baby is delivered, because it's due to hormones secreted by the placenta, which is what sustains the baby. And once that's out, the sugars tend to get better. But there's a 50% risk every year of such a patient developing diabetes. So we keep an eye on their numbers and we test them. The recommendation is to test every 3 years. Everybody, regardless if you don't have any of this risk factor, by age 35, you should have at least one test to rule out pre-diabetes or diabetes. And if those tests are normal, then at a minimum of every 3 years, there should be screening to make sure that the risk has not increased. For those people who have HIV, people who are on certain medications, steroids, for instance, increases the risk of having diabetes and high blood pressure, or who've had inflammation of the pancreas. Remember, insulin is made by the pancreas. Inflammation can lead to destruction, reduced production of insulin. All those patients should also be screened for diabetes, pre-diabetes. And so, why are we doing the screening? The reason is because there's time before you end up needing treatment, about up to, sometimes in some cases, about 20 years, wherein your body is still trying to hang on and make insulin. And if we intervene in this period, this is how we do diabetes prevention. Any intervention, weight loss, eating, exercising, eating healthy, can prevent people moving from the pancreas is still making insulin to the pancreas is quit secreting any insulin. And you notice that the insulin resistance might never change really, but at least we can intervene and around here and help you retain your pancreas function. And as the secretion of insulin goes down, you start seeing fasting, that's without eating food, glucose climbs up. Post EM, a meal, glucose climbs up. So this is the whole point and the reason, the rationale for our talk today. some of the things that have been shown in diabetes. One of the pivotal studies, the diabetes prevention trial, actually happened in the US. And when people with prediabetes reduce their weight by even as low as 5% and maintain this weight loss, whether with 30 to 60 minutes of exercise daily, 5 days a week, or diets that consist of either counting calories, restricting carbs, increasing fiber. The studies in the diabetes prevention program actually showed that compared with even using metformin, people who did lifestyle intervention, diet, exercise, reduced their risk by 58%. Those who took medication reduced by their risk by 31%, which was still significant, but without any intervention at all. Placebo means they didn't have anything, or they will give you something that looks like metformin and you think you're taking a pill, but it's not a pill. So there was no reduction at all. So this is it doesn't get better than this. Without spending money, just some time and effort, you can cut your risk of getting diabetes by 50%, even if you're diagnosed with prediabetes already. And so then I thought you might find this helpful. I certainly have, both personally and with my patients. Each state has a diabetes prevention program. If you go to this website, it's the CDC, the Center for Disease Control and Management, cdc.gov/diabetes prevention, find a program, and you type in your location, whether it's your state's zip code or the city, and you can choose. You can also adjust the radius, either up or down, and then you can even select language options, payment options. There's coverage for Medicare. It will bring up in your area the centers that offer diabetes prevention programs, and it would even tell you whether they're online or you have to be in person. What has been shown in studies that it's helpful when you're doing this together with other people, and it's a series. It's over several weeks where they go over what diabetes is, what prediabetes is, and they can help you with like diet planning, exercise, and all of that. One important slide, and this is like the last slide. I thought it was the most important one. I wanted to leave this up when we answer questions. If you go to this website, and I've been told that all this addresses will be posted so that you have time to take this down. diabetes.org/diabetes-risk.test. This is the American Diabetes Association. It actually has a helpful tool to calculate your risk. Are you at risk of type 2? You put your age and it gives you a score. Anyone less than 40% gets a score of 0. If you're above 60, the highest score is 3. Are you male? Men get 1 point. Women get 0. If you're a woman, have you ever had diabetes during pregnancy? A yes is a 1 point. If you've ever had a first-degree relative with diabetes, that's 1 point. If you've ever been diagnosed with high blood pressure or you're taking medications for blood pressure, that will be 1 point. Are you physically active? If no, then that's 1 point. And then the final question is, what is your weight category? And there's a helpful chart here where on the left-hand side, there's a column with the different heights. And then you go over and look at your weight. And so let's say, for instance, somebody's height is 5 feet 4 inches. If their weight is between 145 and 173, that is 1 point. So you enter that in here. If the weight of someone who's 5 feet 4 inches is less than 145, you get a score of 0 because that means your BMI is great. And so you add all of that together. Anyone with a score of 5 or higher is at risk for prediabetes and diabetes and should get screened with either a fasting blood sugar or the OGTT, which is the test where you drink glucose, or an A1C. And I am happy to take questions. Thank you so much for your attention.
Thank you, Dr. Akambi. Natalie.
All right. Thank you so much for that, Dr. Akambi, and thank you for all who are here. So again, just kind of reiterating what Dr. Akambi did mention is that we know that these lifestyle interventions, whether it's losing weight, making more healthful, eating more balanced meals, and exercising, what a powerful impact that they can have, even absent of any medication, can have on preventing, managing, reversing, and preventing the onset of type 2 diabetes. And so when we think about those things, the thing that they are kind of targeting, kind of as Dr. Kanbi mentioned, is this insulin resistance. So we know that prediabetes is associated with insulin resistance, again, meaning your cells are a little bit more stubborn to this insulin, this hormone that wants to take the glucose out of your blood and into cells or muscle. So now you have this extra glucose in your blood. Thus, we see these elevated blood sugar readings. So our goal with these lifestyle interventions is to help improve, reduce that insulin resistance and help with insulin sensitivity. So helping ourselves respond to that insulin and take the glucose out of our blood and where they need to go, so we have these lower blood sugars. So that is what we were talking about with these lifestyle changes. Again, balanced and healthful diet, regular physical activity and exercise, and other factors that can help with improving insulin resistance and reducing insulin resistance, and improving the insulin sensitivity, stress management, and sleep. So let's just kind of get into it. What are some things you can do? Some diet, nutrition modifications. So the first question I always get is, oh, I have prediabetes, my blood sugars are elevated. Do I need to cut carbohydrates? And the simple answer is no, you don't. The long answer is, well, we need to be informed of what type of carbohydrates we're consuming and be strategic in when and how and with what we are consuming carbohydrates. So let's just kind of talk about my first point is monitoring, identifying carbohydrate intake and their portion sizes. So we have different carbs. We have fiber, we have starch, and we have sugar. So when we talk about the kind of carbs you want to ingest more of, we're talking about those complex carbs. I'm sorry, going back to the other slide. So simple carbohydrates are those refined carbohydrates that have a high glycemic index. So what this means is that these simple refined carbs, the bran is taking out, those essential vitamins and minerals are taken out. And now with the high glycemic index, this means that they are broken down into glucose much faster, which means they get into your bloodstream much quicker, which means they're going to cause a spike and a drop in your blood sugars. So these refined simple carbohydrates are what we want to really reduce, limit, and remove really from the diet as best as you can. These include sugar-sweetened beverages like soda, Gatorade, juice, lemonade, iced teas, and concentrated sweets like cookies, candy, donuts, sweeteners like table sugar, honey, maple syrup. Again, they're digested really quickly, and especially alone, they cause this glycemic response of a spike and a drop, which we don't want. Again, our goal is for more balanced, steady blood sugar. So we need carbohydrates. They're actually our primary preferred fuel for our body. But we want to ingest these complex carbohydrates. So the whole bran is still intact. They're less processed. So now we have all these essential vitamins and minerals like B vitamins. And then we have this fiber. So fiber is a type of carbohydrate that our body actually does not digest. And instead, it is used to help absorb and slow down the breakdown of carbohydrates. So thus, we have this less of a rise and a fall, but more of a steady. So fiber is very, very important. So these complex carbs I'm talking about are like whole wheat bread, right? Whole wheat pasta, barley, brown rice, oatmeal and bran flakes, and also things like fresh fruit, starchy vegetables, and like beans and legumes. So we want to actually increase these type of complex carbohydrates, replacing these complex carbs with those simple carbs. So instead of consuming simple carbs, you want to replace them with these complex carbs. So going on to the next slide, my next point, as I had mentioned, is we want to consume these carbohydrates, but we need to be mindful with how much and with what. So pairing with other macronutrients like protein and fat and fiber-rich foods can be beneficial in maintaining a stable blood sugar versus a rise and a fall. So I want to introduce you to the plate method. I love this because it's a wonderful visual of how you can balance your meals, right? It promotes balance. It promotes a variety of these nutrients we need in a controlled portion. So as you can see, our carbohydrates are a quarter of our plate, and the plate method shows us that the other quarter is protein, and half of our plate should be filled with these non-starchy vegetables. And you can see in the middle here a blue circle, that's our fat, because we want to be moderate with these. So again, reiterating, see, these carbohydrate foods aren't taking up our whole plate, except they are paired with protein, these fiber-rich foods, and healthy fats. So remember these I remember understanding what carbohydrates are and identifying them. So we find them in milk and yogurt, rice, pastas, oatmeal, cereal, fruit, starchy vegetables, beans, and legumes. Okay, so on the next slide, let's talk about those non-starchy vegetables, which should be making up half of our plate. So filling up with these fiber-rich, I mentioned, is super important, filled with vitamins and minerals. These non-starchy vegetables are full of these phytonutrients, or these antioxidant containing properties that are cancer fighting, disease fighting. So half of our plate are these non-starchy vegetables like asparagus and broccoli and cabbage and carrots and peppers and onions and leafy greens, spinach, kale. Okay. And moving on, the other portion, that quarter of our plate, is our protein foods. Okay, so protein is a macronutrient. This is on the next slide. When we're talking about protein, again, is a macronutrient we need. These are the amino acids, the foundation to build and repair cells and tissues and muscle. Okay. And we also know that protein can have some insulin sensitizing properties, meaning they help, right, to keep that blood sugar low, and they are digested slower. So again, when paired with these carbohydrates, they slow down digestion and they help to promote more of a balanced, steady blood sugar versus rise and a spike. So we do promote more lean protein foods, so like turkey and ground chicken breast, salmon, eggs. These are the kind of protein-rich foods that we want to consume. And moving on to our fats. Remember, kind of as Dr. Akambi mentioned, with prediabetes, you also have a risk of developing other chronic diseases, which include cardiovascular disease. So we want to be mindful of the type of fats that we consume and eating more healthy fats like mono and polyunsaturated fats versus saturated fats. A high amount of saturated fats, we know, can also be linked to increased levels of LDL cholesterol, right? High cholesterol. And this is also a form of inflammation and does not help with insulin resistance, and it could make this worse. So these healthy fats we want to consume are like olive oil, avocado oil, whole avocado, nuts and seeds. But remember, it is a small portion to add in your meals or your snacks. We want to still be moderate about these. Limiting saturated fats like stick butter, stick margarine, deep, fried foods are going to be high in those saturated fats. All right, so our next slide here. So again, reiterating the plate method, which is promoting whole fiber-rich foods, right? Consuming less processed foods and more of those whole foods like fruits and vegetables and beans and legumes that are high in fiber, that type of carbohydrate that slows down absorption and helps balancing blood sugars. And these also have some insulin sensitizing properties that we are looking for with prediabetes. And last, but certainly not least, on the next slide here, we're going to talk about exercise. Okay, so we know this can be very, very beneficial in managing our blood sugars, lowering our blood sugars, because when you increase exercise, you're also increasing the insulin sensitivity and thus helping to lower your blood sugars. So as kind of Dr. Akambi mentioned, a program of a regular, moderate physical activity really for 30 minutes a day, 150 minutes of exercise a week is what we are looking for. And also regular physical activity, okay? So the ADA actually recommends that when sitting for long periods of time, to break up those long periods of time with every 30 minutes, 3 minutes of some light activity. So remember, when we move our body, when we move our muscles, we are thus asking, we need that energy. And so it's helping to lower that blood sugar. Something else I'd like to mention, including that physical activity, which cardio is great, but I always challenge people to increase their resistance or their strength training, okay? So remember, what your blood sugars want to do is they want to be taken up by cells, and they actually want to go into muscle. So if you do some resistance training and you're building up that lean muscle, that not only helps with, longevity and reducing your risk of getting hurt. As we get older, we lose muscle mass. Now we're building up that lean muscle. And now if you have more muscle, the glucose, your blood sugar, has more area to go into. And it's a non-insulin mediated lowering effect on your blood sugars. Okay. And lastly, let's just quickly review a food label. So in the first slide, when we talked about those simple refined carbohydrates, those sugars, right, like added sugar, we know that these in excess can increase that insulin resistance. So when we're looking at a food label, and I hope you all can see this, I tried to highlight it. The very first thing you want to do is look at that serving size, okay? So serving size isn't necessarily a recommended portion. It's just telling you the rest of all these numbers here are for this serving size. So where you can see here, it's one slice. If you're making a sandwich, it's important to know that because you might be using, right, 2 slices of bread. And so now everything is doubled, okay? So very important to note that serving size there. And then, as you can see under there, a few lines down, we have total fat, then we have cholesterol, sodium, total carbohydrates. Okay, so that is your fiber, your starch, and your sugar. Okay, that's the total of those. And then underneath that, it tells you of those total, how much of it is dietary fiber. Remember, we want high amounts of fiber, right, to slow down the absorption of carbs to help improve our balance of blood sugars. And then under that will be total sugar, okay? So total sugar does include natural sugars, okay? Naturally occurring sugars, like in fruits and starchy vegetables, we know are also paired with fibers. We don't necessarily have a limit on that, but what we do want to reduce are those added sugar. And on a food label under total sugars, it will tell you how much of those sugars are added, meaning they are not naturally present in the food, but they are added, whether it's regular like table sugar or honey, okay, things like this. And so this is what we want to really limit and keep low. Thank you so much. And again, I'm happy to answer questions.
Thank you, Natalie and Dr. Akambi. There are some questions that are popping up in the chat, private chat. Metformin, Dr. Akambi, is it bad for blood pressure?
So metformin has no effect on blood pressure. It's a medication that improves your insulin sensitivity and also makes your liver stop pouring out tons of glucose. A lot of people will say, oh, I wake up and my glucose is high and I didn't even eat anything overnight. That's because apart from just issues with insulin, there's 7 other things happening with type 2 diabetes. One of them is your body is always making glucose round the clock, even if you don't need it. Most of that tends to come from the liver, and metformin, it's thought, helps to block those two things, helps your muscle use insulin better, makes your liver stop pouring stuff out, doesn't have any role on blood pressure, no side effects that will affect your blood pressure either.
Natalie, what about eating late night? Is that good or bad?
It's not good or bad. So when it comes to that theory, like don't eat after X amount or X amount of time, I always recommend, trying to limit your last meal or your last snack to maybe 2 or 3 hours before bedtime. Okay. So if you go to bed at midnight, and you have a snack at 9, right? Or 10 or something like that, right, we just want to limit it to a couple hours before bedtime. But if that is your last snack and that goes into your total calories for the day, that's okay. It's again just that time frame before bed, about 2-3 hours, your last meal or snack.
Okay. There's a question from a wife whose husband says, I work construction. I don't need to exercise.
Dr. Kambi, do you want me to answer that, or what do you?
You can start, and then if there's anything else, I'm sure you handle.
So, but certainly if you're in construction, I'm assuming you're moving around a lot, you're pretty active, and this certainly helps, okay? But sometimes that intense physical activity, really getting your heart rate up, is known to really get, lower your blood sugars and keep them low, and they have this insulin sensitizing components for long periods of time. So it's great actually to have a very active job. It keeps you very regular and active throughout the day. So that certainly has its benefits. But I do believe in some moderate, a little more intense, moderate again, for 30 minutes a day. But that's certainly a good start, right? Not being sedentary.
I agree with you, Natalie. Yes, thank you. I agree with you, Natalie. And also to say that part of exercise is also not just for diabetes and weight loss, but also for heart health. It's beneficial for high blood pressure. And what's been found in research is your heart rate going above a particular amount for your age also is a pointer, not just to how well you do for blood pressure or glucose, but also whether we should be worried about blocked vessels, because we expect your heart rate to keep up. When you do a treadmill test, they actually measure heart rate for that reason. And if you don't have your blood pressure and looking what the way it's supposed to, or even your heart rate, that's a concern. When you exercise, we say that you want to be a little bit breathy when you're talking. That's what we find as helpful, except like Natalie said, any form of exercise is better than none, but having something a little bit more formal is always welcome. Okay.
I'm not sure which one, but if you eat the right foods, but you eat a lot of them, is it harmful?
So, that's where the plate method comes in, because it's promoting not a high amount of any of these macronutrients, but more of a balanced amount. So that can be, right? Consuming a high amount of fats can be harmful, and consuming not enough of those fiber-rich, non-starchy vegetables and not getting those vitamins and minerals, sure. So I think, yes, having a very high amount of one certain macronutrient can kind of cause a deficiency if you're not getting in those other variety of foods that we need. So again, we're promoting a balanced plate, right? So half of your plate non-starchy vegetables, a quarter carbohydrate foods, a quarter protein, and some healthy fats. So we get a variety of these nutrients, a nice balance, the right portions. It helps to visualize that. And so we have these balanced blood sugars.
Dr. Okambi.
Yeah, thank you. If I may, I'll add that it's important. I absolutely agree. The plate method is making sure you're getting all the major food groups in the right portions. It's also important to know that yes, Natalie pointed to this. Carbs are not bad. They're the major fuel. If you don't get carbs and you're doing keto or mainly protein, your body does convert those to glucose. Because take your brain, for instance, your brain uses glucose only. You need to have been fasting for nearly 2 days before the brain says, okay, I'll use some fat. Now I'm out of glucose. So you do need glucose. Your body will find a workaround to make that, whether it's going to make it from protein and make it from fat. Remember, that's why people lose weight before diabetes is diagnosed, because yes, there's a lot of glucose, insulin isn't there. Your body goes and finds, I have stores of protein. I'll break those down and convert to more glucose. I have stores of fat. I'll break that down and convert it to more glucose. So don't focus on one at the expense of all the other major groups. It's good to get the right amount.
Dr. Akambi, this is from Karen, Kathleen rather. Are people with thyroid disease more prone to be diabetic?
So people with thyroid disease, if it's under functioning, which we call hypothyroidism, potentially you could gain weight. The weight can make you insulin resistant, and then maybe you might have some degree of prediabetes, but it doesn't always mean that because I have thyroid disease, I'm going to have diabetes. Having said that, if the thyroid dysfunction is autoimmune, which is your body thinks your thyroid belongs to somebody else, just as your body thinks your pancreas is someone else's own and tries to destroy it, there is a potential for autoimmune conditions to cluster together. So someone can have autoimmune thyroid disease and also can eventually end up developing type 1 diabetes. Usually this is the autoimmune form of diabetes that people then can have an association with. Oh, I have rheumatoid arthritis or lupus or some celiac disease, then there's a risk that your risk of having type 1 diabetes is higher than people who don't have those autoimmune diseases. The highest risk for getting diabetes really is from it's hereditary in terms of family history, parents, and also lifestyle, especially for type 2.
Thank you. From Deborah, is exercising late at night effective?
I mean, I would ask, what time are you going to bed? Remember that another contributor to helping with improving insulin sensitivity and reducing insulin resistance is getting adequate amount of sleep. So if you're exercising late at night and you find that it affects your sleep, then I would recommend moving it up, to, again, something like 2, maybe 3 or 4 hours before bedtime. That way your body has enough time to kind of wind down, because when you exercise, wonderfully so, you are increasing your energy levels, your endorphins. And so if you're doing it too close to bedtime, that would be my question, is it may affect your sleep. And we know that sleep is very important. So, but it wouldn't have any special benefits, I suppose, when compared to exercising in the morning.
Okay. 2 questions here. One from Scott, then Mary. How does intermittent fasting hurt or help diabetes conversation?
This is a really good question. Yeah. So there have been studies showing with intermittent fasting a improvement in insulin sensitivity and reduction in insulin resistance. And in theory, it kind of goes down to, when intermittent fasting, you are reducing your total caloric intake. And with that may come weight loss, which we know helps improve insulin sensitivity. So I always use it as a tool. I say it's a tool in the toolbox, right? So in practice, I don't necessarily always say, please do intermittent fasting. It doesn't work for everybody, right? We have to find sustainable changes that work for your lifestyle. Okay. And there may be times if you're doing intermittent fasting and you're going really long periods of time, because there's many different ways and methods for intermittent fasting, and some have a short period of eating time and some have a little bit more. And so if you are going a long period of time without eating and then you are eating a larger meal, this can cause a more postprandial spike in your blood sugar, right? And it could be beneficial having consistent meals, right? Like 3 meals and a couple snacks. So again, I use it as a tool in the toolbox. But in overall reduction of balanced eating or reduction in caloric intake, I just say it depends on your lifestyle. So a tool in the toolbox.
Thank you. Dr. Akambi.
Yeah, and could I just add a little
Yeah.
bit to this? Sorry, I just want to state if you have a diagnosis of diabetes and you're doing intermittent fasting, please do this in conjunction with your provider, because if you take insulin for meals, hopefully everybody knows this. If you're fasting, you should not be using a Novolog or Humalog or any of those kind of insulin. And maybe if the dose of your long acting is correct when you fast, you shouldn't have issues. But your medications might need to be adjusted because you're doing intermittent fasting and not having as many calories. And hopefully when you lose weight, you also end up needing less insulin, or even maybe some of your medications, their doses might need to be adjusted down. But great question.
Yes, absolutely agree. And that was kind of despite any kind of medication or insulin, right? So absolutely.
One more. Dr. Akambi, what's the difference from prediabetes and diabetes? I think you answered that in your chart, but it popped up on the screen.
Okay, so prediabetes is the condition before. In medicine, we have a host of things, like even for high blood pressure, we have numbers that the top number might be high, the bottom number might be high, and we're like, okay, we should be keeping an eye on things. Osteoporosis, we have a condition that precedes it called osteopenia, where we're like, you're not fully there where you're at risk of breaking a bone, but if we don't intervene, your risk goes high. So same thing with prediabetes. Your body's telling you, I'm barely hanging on. Do something before diabetes ensues. That's what prediabetes is. Because really it's to back up and go a little bit into physiology, every time whether we're sleeping, round the clock, your body is making insulin. Then when you eat, it makes a lot more. Prediabetes is it's still able to make a lot more, but it's really working overtime to do that. And sometimes when you're even fasting, it's struggling. There's no food to put pressure on your pancreas, but it's holding on by a toenail, barely chugging along. If we intervene, we give it a breather. It's not as under pressure. There's not as much stress. Maybe you can leave without even we know that 50% drop in the risk of getting diabetes happens for each person that makes this intervention. So it's a really important thing to pay attention to, because we stave off all these complications, the cost, and the effects on lifestyle and quality of life.
Thank you, guys. Let's all join in thanking Dr. Akambi and Natalie for joining us today. They mentioned earlier that the next series in this program will be next Thursday, April 18th at 10 a.m. And we will continue the series with a program on type 2 diabetes. The event will focus on the impact diabetes can have on your body from head to toe, including brain health and strategies on how to live well through disease management and care goals. The link to register is in the chat, and you can use the QR code on the screen. Thank you all so much for coming, and we look forward to seeing you next week. Thank you, guys.
Thank you so much for having me.
It was my pleasure. I really appreciate the invitation. Thank you.
I learned a lot.
Great. Have a good day.